Before I knew it, it's 7 o'clock in the morning. Good morning, everyone. Good to see you. First of all, thank you for being here. We're really honored and lucky to have the opportunity to present this to you. And actually, this subject matter is something that is near to dear to all of us. You know, it's a rare tumor, and the fact that in itself is being highlighted in an industry-sponsored symposium, I think, just shows how important it is and how much more we need to do a better job in educating and getting the word out. I hope everyone's been enjoying the annual meeting. I think today is a travel day for a lot of us, so hope you're here safe and enjoy the great city of Seattle. I won't say any jokes. The fact that I'm flying back to Miami Beach and it's 77 and sunny, and here it's not. So I'm Brian Slomovitz. I'm going to be the moderator this morning's session titled Advancing Care in Recurrent Low-Grade Serous Ovarian Cancer. It's going to be a case-based approach. You know, it's really, for me, I'm humbled. It's an honor to be here on stage with my friends and colleagues, and really the leaders in the field. When you look at the ongoing trials and the ongoing prospective research that's going to change the world, the three colleagues of mine that are here really have made a huge impact in that. So Dr. Isabelle Ray-Coucard, from France, so she'll be flying back tomorrow. She's a nonstop, which she's excited about, and she's going to enjoy Seattle this afternoon. Hopefully the weather will stay above 55. Dr. Rachel Grisham from Memorial Sloan Kettering, and Dr. David Gershenson. You know, I did my fellowship at Anderson, so he was my boss there when he was the chair there. But either way, to have all three here, it's really, I think you'll be able to get a lot out of the session this morning. Here are our disclosures. This is an accredited program allowing you up to 1.25 hours of CME credits in compliance with ACCME regulations. The GOG Foundation, as the accredited provider of this activity, we must ensure that anyone in a position to control the content of the educational activity has disclosed all relevant financial relationships with any commercial interest. A designated official manages all reported conflicts to ensure bias-free presentation. In other words, we made the content, no one made it for us. And it's independent of any influence. To claim credit for this course, you must complete the pre- and post-evaluations. While we're engaging in the opening comments, please use the QR code on this screen. I'll leave it here for a moment. It's also on the tables to complete the pre-test survey. So let's do a quick review of today's program and then get started. Here's our agenda. The GOG Foundation would like to thank Veristem for their unrestricted educational grant in support of this program. And our objectives, we're also going to be incorporating discussions of the frontline therapy. So we really want to take you through the course of initial diagnosis and management in the frontline, through what's going on currently in the recurrent setting, and finally leading up to Rachel's going to be talking about the latest and greatest and where we're going in the future. We really need to stay on schedule. We'll be strictly enforcing the time limitations for our presentations. Without further delay, I'd like to welcome Dr. David Gershenson to discuss the current clinical landscape of first-line therapy for newly diagnosed patients with low-grade serous ovarian cancer. Dr. Gershenson.
Thanks very much, Brian. Yeah, so as Brian said, this session is primarily related to management of recurrent low-grade serous ovarian cancer, but we thought it was appropriate to also, for a little bit, discuss frontline therapy. So this is a slide that shows some of the principles of primary treatment of low-grade serous ovarian cancer, and as you know, primary surgery is the preferred approach. If an ultrasound shows a complex ovarian mass and CA-125 is elevated, most of the criteria suggest that a patient like that is referred to a gynecologic oncologist. The surgical procedure is pretty straightforward. If the tumor apparently involves just the ovary or ovaries, and there's no evidence of metastatic disease, then in a woman who's completed childbearing, hysterectomy, bilateral salpingo-oophorectomy, and then comprehensive surgical staging is appropriate. But there are those young patients who've not completed childbearing in whom fertility-sparing surgery may be an option. It's particularly if they have only one ovary involved. There is the opportunity to preserve the uterus and contralateral normal ovary. Some of these patients do undergo oocyte retrieval following their initial surgery. But if the tumor is obviously metastatic, which is the case in the majority of women with low-grade serous ovarian cancer, then the principle is maximum cytoreductive surgery to achieve no gross residual. And there have been a number of studies that have been reported on primary surgery for low-grade serous ovarian cancer. The first was Amanda Fader's paper in 2013, which was an ancillary study of GOG 182. But as you can see, the trend for all these papers is the same. And patients who have no gross residual at the completion of primary surgery have much better outcomes in terms of progression-free survival and overall survival. There are some important considerations once a patient has undergone primary surgery. So one question is, should a second opinion be requested on the pathology? There are a lot of nuances involved in the diagnosis of low-grade serous carcinoma. You know, serous borderline tumor is coexistent in about 60% of primary cases. The distinction between serous borderline tumor and low-grade serous carcinoma sometimes can be very tricky. And we still are seeing patients referred to us who have a diagnosis of high-grade serous ovarian cancer, and when the pathology is reviewed, it actually is low-grade serous ovarian cancer. I had a patient last week who was treated in a comprehensive cancer center, had the diagnosis of high-grade serous ovarian cancer, and she really had low-grade serous ovarian cancer. And then there's the very exquisitely rare low-grade serous, high-grade serous. Patients may also choose to seek a second opinion on clinical management. I generally recommend a postoperative baseline CT scan of chest, abdomen, pelvis following primary surgery. And I also recommend that all patients have genetic testing as well as genomic profiling and also folate receptor testing. But regardless of postoperative treatment, the monitoring is basically the same, and patients are seen about every 3 months for the first year, and then gradually less frequently with CA-125 and imaging. So a few words about first-line systemic therapy following primary surgery. So we know from several studies that platinum-based chemotherapy alone is just not the optimal therapy for these patients. And there are a number of studies to show that, and you can see on the right-hand columns, particularly the median overall survival is not what we would see with contemporary management of low-grade serous ovarian cancer. So we do not recommend chemotherapy alone any longer. In 2017, there were two retrospective studies reported, one from our group at MD Anderson, in which we reviewed 203 women, 133 of which had primary surgery followed by platinum-based chemotherapy alone, and the other 70 had the same but followed with hormonal therapy, aromatase inhibitors, tamoxifen, et cetera. And we found that the median progression-free survival was significantly better for those women who underwent endocrine therapy following chemotherapy, with a median progression-free survival of 65 months versus 26 months. The overall survival was not statistically different, although there was a trend. And then Amanda Fader at Johns Hopkins in the same year reported 27 women who underwent primary surgery for low-grade serous ovarian cancer and then went straight to hormonal therapy. They did not have a long enough follow-up to have a median overall survival or even progression-free survival. However, their 3-year progression-free survival and overall survival sort of overlaid what we saw in our study. And this led us to develop NRG-GY019, which is a randomized phase 3 study. Amanda Fader is the PI. And after patients undergo primary surgery for stage 2, 3, or 4 low-grade serous ovarian cancer, they are randomized to either paclitaxel carboplatin chemotherapy followed by letrozole maintenance therapy, or they go straight to letrozole monotherapy. And that study is a non-inferiority trial, 450 patients, and I'm happy to tell you that the accrual should be completed, and we think about May or June of this year. And so hopefully we'll have an answer in the not-too-distant future. This is the NCCN guideline, which is, a lot of this is based on retrospective studies that have been performed, and it's mainly expert opinion. But you can see for stage 1A or 1B, postoperative management is observation or surveillance. For stage 2, 3, and 4, it is the 2 options that are in Amanda's trial. You can see for stage 1C, it's all over the place. It's observation, it's chemotherapy followed by endocrine therapy, or it's endocrine therapy alone, and that just tells you that for stage 1C, we really do not know what the optimal management is. I think we have a real missed opportunity in that we haven't taken advantage of a drug that's very active in low-grade serous ovarian cancer, and that's bevacizumab or Avastin. And there are 2 studies, one from 2014 and another from 2017, that show us that bevacizumab is very active in recurrent low-grade serous ovarian cancer, usually combined with chemotherapy, with response rates above 40%. And there was a study that was reported very recently from Italy, in which this was, again, a retrospective study in frontline use of bevacizumab, in which they compared patients who underwent chemotherapy alone following primary surgery to those that had chemotherapy and bevacizumab. And what they found was that, as you can see, the response rate was, although a small number of patients who had measurable disease following surgery, the response rate was better. But if you look at particularly the median progression-free survival, 47.9 versus 22.8 months, so very significant. So I think we've missed the opportunity to maximize the use of bevacizumab. I think in Europe it's used more frequently than it has been in the US, but I think that may change over the course of the next few years. So then a few words about neoadjuvant chemotherapy. It's not the preferred approach. Primary surgery, as I've said, is. However, there are a small number of patients who, for reasons of very extensive disease or comorbidities, are candidates for neoadjuvant treatment. But we think this decision should be made by a gynecologic oncologist. The only modalities we have for decision-making are either imaging or laparoscopic assessment of the tumor to determine if it seems to be resectable. And neoadjuvant treatment usually involves 3 to 6 cycles of chemotherapy in a standard way, followed by interval cytoreductive surgery and then more systemic therapy. Interestingly, 2 studies recently reported have documented an increase in the use of neoadjuvant treatment for patients with low-grade serous ovarian cancer. So that's a trend we would like to reverse if possible. There are a couple studies, one from our group at MD Anderson by Lauren Cobb, in which she compared 36 patients who underwent neoadjuvant chemotherapy. This is platinum-based chemotherapy alone for low-grade serous ovarian cancer, and she compared them to matched patients with high-grade serous ovarian cancer. And you can see that the response rates are very different. 11% response rate for patients who had low-grade serous ovarian cancer, 75% for high-grade. You can also see in the right-hand column that the median overall survival was pretty poor in this group of patients. And then there was a small study from Memorial Sloan Kettering, and they also found a 9% response rate with chemotherapy. This led us to conduct this pilot study of abemaciclib and fulvestrant as neoadjuvant treatment for women with low-grade serous ovarian cancer. And then, as you can see, there was an algorithm, and they were triaged, eventually most of them to interval cytoreductive surgery. And the results of this trial were distinctly different. So on the left-hand of the slide, you can see that, again, 11% overall objective response rate to chemotherapy, and we had a 60% response rate to fulvestrant and abemaciclib. So this is an approach, a strategy that I think is worthwhile to continue to study. And then at Memorial Sloan Kettering, there's also a neoadjuvant trial with avutometinib and defactinib plus letrozole for patients who are deemed not to be resectable initially. And again, you can see that most of one arm of this is to have interval cytoreductive surgery, although they may go off trial if they develop progressive disease and so on. So this is also, I think, a unique strategy to get away from chemotherapy for these patients. So I'm going to end with a case. This is a 28-year-old woman who presented with pelvic pain. Ultrasound revealed an 8-centimeter complex ovarian mass, suspicious for endometriosis. She was seen by an obstetrician gynecologist. She had no CA-125 or CT performed preoperatively, and she was taken to surgery for a laparoscopic left salpingo-oophorectomy and biopsy of a cul-de-sac mass that was found at the time of surgery. And both of these revealed what was called high-grade serous ovarian cancer. She was then referred to a gynecologic oncologist who performed a CA-125, 306. A CT scan showed an omental mass as well as a mass posterior to the uterus. And she underwent cytoreductive surgery, as you can see there. And pathology, again, in this institution showed high-grade serous ovarian cancer, stage 3C. But she sought a second opinion and went to an academic center. And at that time, the pathology was re-reviewed, and she actually ended up having low-grade serous ovarian cancer, not high-grade serous ovarian cancer. Genetic testing was negative, and genomic profiling revealed no mutations. So the question here is, what's the preferred postoperative therapy for Lillian? I think we all would say if there is a clinical trial available, that would be the first option, and right now, GY019 would be such a trial. If the patient is not interested in a trial, or if a trial is not available, then what about the other options? Well, hopefully I've convinced you that chemotherapy alone, carboplatin and paclitaxel, is not a good option for these women. The two standard options there are, as I say, carboplatin and paclitaxel for 6 cycles, followed by letrozole maintenance therapy or letrozole monotherapy. But as I've mentioned, I think, again, we haven't taken advantage of bevacizumab as much as we should, and I think in the future we may see that integrated into frontline therapy more commonly. Of course, once GY019 is completed and we have an answer, because it's a non-inferiority trial, if in fact letrozole monotherapy is as good as chemotherapy followed by letrozole, then chemotherapy will go away for frontline treatment. But that doesn't mean that bevacizumab couldn't still be integrated into frontline therapy. So I will turn it over now to Isabel. Thank you very much.
You know, that was great, and we have 3 minutes. I just want to ask the panel something, because I think as we move forward with potential approvals and things like that, we're going to be facing this. And we've talked about this lately with endometrial cancer particularly, but in high-grade serous. For the panel, if you get a patient sent to you, newly diagnosed, early-stage disease, the pathology report simply says low-grade serous ovarian cancer, what biomarker testing are you doing up front? Even in just a patient with a diagnosis, are you doing biomarker testing then, or are you going to wait until they're either advanced or recurrent? Isabel, I'll start with you.
Yes, in France, except ER, PR, and P53, that
Okay.
it's helping to do the diagnostic, we did not ask too many other biomarkers. We are waiting for advanced stage or for relapse.
Okay, so P53 and ER testing. Rachel, same thing, or because I know we're going to be looking at KRAS mutations, the differentiation of tumors.
Yeah,
How
so
soon?
in addition to IHC testing, you know, luckily we have those national guidelines in the United States by NCCN and SGO, which do recommend that germline testing and somatic testing be performed on all newly diagnosed patients with ovarian cancer. And that's irrespective of histology. So I routinely do germline testing and somatic tumor testing on all my newly diagnosed patients. And for low-grade serous ovarian cancer, while this generally doesn't affect our upfront therapy, it does have prognostic implications that can help us in counseling patients. And also, it's just important information for us to have for future lines of therapy.
Anything different in Texas?
Yeah, we do the same as Rachel. You know, it's recommended all patients have genetic testing and somatic tumor testing. We also do folate. We do IHC for ER, PR, et cetera. So, yeah, we do it even if they have early stage disease.
Oh, so I guess in summary, you're saying get the information as soon as you can and get the
Yeah,
biomarkers.
it's for future reference primarily, obviously. But, you know, we've had some patients, for instance, about 2 to 4% of low-grade serous ovarian cancer patients have a BRCA mutation, a germline BRCA mutation. And some of those patients, when you look a little harder, actually have low-grade serous, high-grade serous ovarian cancer. So I think these things are
For diagnosis as well.
important in diagnosis.
And thanks for finishing early. One question, and I just want a quick answer. It'll be yes or no. Do you think we're going to be getting rid of chemotherapy in the first-line management of low-grade serous ovarian cancer? Rachel, we'll start with you. Getting rid of chemotherapy.
Well, we'll find out soon with the results of the study, but I think no. For the moment, I think in the future, yes, but I think for the immediate future, no.
Isabel?
Perhaps.
Perhaps. That's riding the fence. And Dr. Gershenson?
I don't think so. Not in the near future, but it's a guess.
And to remind everyone, we will have time for questions at the end, and there's microphones throughout the room, so I know the panel looks forward to your questions. Without further delay, I'd like to introduce Dr. Isabelle Ray-Coukard to present a patient case that will give you further insight into the incorporation of management in the recurrent disease.
Thank you very much, Brian. To illustrate the management of patients in the relapse setting, we propose to discuss a case from the Centre-Lambert, which is today a 61-year-old patient, but at the time of the diagnostic, she was younger. It's a low-grade serous adenocarcinoma diagnosed in 2002 with no comorbidity, no concomitant medication. By the way, she is a doctor. And we see these cases with an advanced stage, a FIGO stage 3, ER positive, PR negative. She received a cytoreductive complete surgery plus 6 cycles of chemotherapy, adding carboplatin paclitaxel. 9 years later, she relapsed with a supradiaphragmatic lymph node recurrence, and she received again carboplatin, gemcitabine plus BEV, followed by BEV as a maintenance therapy for 18 months. How we can propose this kind of treatment for this patient? What is the evidence we have? As David proposed before and show you, the activity of chemotherapy in this disease is very low. And we don't have any randomized trial to make a clear evidence of what could be the best drug for this patient. We just have retrospective data who report some cases with some response, stable disease. Also, we know that in this disease, the stable disease is not always very easy to interpret as we are speaking about indolent disease. However, we see some activity with carboplatin, we have some activity with gemcitabine, and at the time of the relapse of these patients, the Ocean trial were available, and for this reason, and because we have retrospective data to consider that BEV in combination with chemotherapy could be a good option for this patient, and you can see the detail of the trial already presented by David in terms of response rates, we consider that it could be a good option for this patient. And so she received the treatment and then continued the surveillance. 3 years later, she relapsed, but it is a loco-regional relapse considering cervical lymph node. And so as it is quite an oligomet relapse, we consider that surgery could be a best option for this patient. Again, how we can consider surgery as a good option in this disease? First is an indolent disease, and we know that in case of indolent disease, surgery is sometimes one of the best options. Considering the data we have in the literature, we don't have so many data dedicated to low-grade serous carcinoma. We have this retrospective analysis, including more than 40 patients, where we see that the patients were able to receive a second cytoreductive surgery. What it is interesting to look in this publication is that you can see that unfortunately the majority of the patients in the initial diagnosis were not able to receive a complete cytoreductive surgery. It's an important message, and David insists on that. We need to be very careful about the quality of the surgery in upfront line. And when we move to the relapse setting, we see that the majority of the patients, more than 60%, receive this second surgery as a primary care, but there is some patient who receive chemotherapy before to move to surgery. We don't know exactly in the publication what the chemotherapy brings to this patient, perhaps just to see if the disease is quite indolent and we have time to move to the surgery. But at the end, this patient receives surgery, and as you can see, there is a majority of patients who receive cytoreductive surgery but with residual disease. And what it is important in this publication is that we see a clear difference for the patient who receive surgery with no residual disease compared to the patient who receives surgery with residual disease. And the question it will be important to know in the future is, do we have to propose surgery when we are not able to propose a complete debulking surgery for this patient? It will be an important question. The importance of the quality of the surgery in the relapse setting was also revealed by the multivariate analysis, where you can see that finally the size of the disease and the quality of the disease are the two major prognostic factors to explain the PFS and the overall survival of this patient. So our patient received this surgery and continued the follow-up for 3 years. 3 years later, we see again a relapse. It is a mediastinal lymph node relapse, and for this reason, the patient did not receive surgery again, but radiotherapy. 2 years later, she has a new relapse, again, a cervical lymph node relapse. We confirm by biopsy that the expression of ER continued to be positive, and as we have an ER positive disease, we propose to the patient letrozole. Again, what is the data we have to confirm hormonal treatment for this patient? We have several retrospective data. The most recent prospective phase 2 was delivered with an anastrozole for the Paragon trial. And you can see in this subgroup of patients with 36 patients, the majority were low-grade serous. There is some borderline tumor in this phase 2, but if we don't see a huge number of patients in response rate, the clinical benefit, and more importantly, the median PFS of close to 1 year were very convenient compared to what we see with chemotherapy. And so our patient received letrozole, and as you can see, we have exactly the median PFS as we seen in the Paragon trial. 1 year later, unfortunately, she relapsed with supradiaphragmatic lymph node, but also pulmonary. And for this reason, the patient received chemotherapy again. But as we see some response, it's not really a partial response. It's some shrinkage of the disease. The surgeon decided to move to an interval debulking surgery in June 2021. Then she received again 2 cycles of chemotherapy and start the follow-up. Unfortunately, few months later, she presents again a progressive disease with a lymph node and lung met, with also some symptoms on the coda equina we will discuss again. And as we are at the time of the biology, we were able to deliver a molecular analysis who confirm a BRAF V600E mutation. And how it is important? It is important because we know that in the low-grade serous carcinoma, if ER and PR positivity are quite similar that we see in the high-grade serous ovarian cancer, in terms of molecular profile, it's completely 2 different diseases. If we see some BRCA and HRD positive tests in high-grade serous, in the low-grade serous, the most important is really the MAP kinase pathway alteration, where we see now that we have between 30 to 40% of patients where we can see some alteration. So today, it's fundamental to look at this alteration for your patient. And considering this pathway, one of the most interesting treatments we can propose is the MEK inhibitor. The first one we see some activity was with the selumetinib, where we see a response rate of 15%, but more importantly, a median PFS of close to 11 months in this population where you have seen that chemotherapy did not bring so much results. In this phase 2, we don't see a correlation between the activity of selumetinib and KRAS or BRAF alteration, but we see the first signal to consider MEK inhibitor as a good option for the patient. The next trial published was the MILO trial, is a phase 3, exploring the binimetinib in this population compared to what we call standard of care, that's mean chemotherapy, PLD, paclitaxel, or topotecan. The trial unfortunately stopped because of futility. We were not able to make the demonstration that this MEK inhibitor is better than chemotherapy in the relapse setting, considering the BICR or the investigator analysis. But interestingly, Rachel reports several years later, looking to the KRAS MAP kinase alteration, that there is some activity using this MEK inhibitor if the patient has such a kind of mutation compared to standard of care. And this difference was not observed when we are using chemotherapy. The most important trial until now we have seen is the GOG 281, exploring another MEK inhibitor, the trametinib, compared to standard of care, including chemotherapy and hormonal treatment. A crossover was organized in this phase 3 trial. David reported these very nice results at the ESMO 19, where we will be able to see for the first time a huge benefit to use a targeted treatment in this population compared to chemotherapy or hormonal treatment. The other ratio is 0.48. And also we see 68% of crossover in the placebo arm, in the standard of care arm. We see a trend in favor of the overall survival to use this MEK inhibitor compared to the control arm. This is the same for the response rate. We see a huge difference using this drug compared to the other in terms of response rate, but also in terms of median duration of response. And I know that this drug is available in US right now for your patient, that it is not the case in Europe because the pharma company did not bring any label for this drug. At the time, we have also this bouquet trial. It is a Roche-sponsored trial where we have the opportunity for all rare ovarian cancer epithelial histology to receive an NGS platform analysis, and looking to the molecular alteration we are observed, we can propose several monotherapy or combination. And looking to what we see with the BRAF mutation for our patient, she received cobimetinib in this trial with 60 milligrams per day, 3 weeks on, 1 week off, and we start at the beginning of 2022. After 2 months, we see immediately a partial response looking to the lung met, but also at the lymph node level, a very quick tumor shrinkage, and in June 2022, the patient was in complete response. In April 2024, 2 years later, the patient started to have some sensory deficit, and she come back to the hospital. We receive a lumbar puncture where we see tumor cell. However, we don't have any prior examination, and so we decide to deliver an MRI exam where we see the disease exactly at the localization where we can anticipate the symptom. This leptomeningeal disease, when we go back to the first CT scan, we see finally some alteration that we can anticipate that this disease was already there at the beginning of the trial. But more importantly, when we interrogate very strongly the patient, we realize that she decreased the dose of the treatment since more than years. And when she feels the new symptom, she restarts immediately the treatment, and after 2 weeks, the symptoms disappear. So we consider that the treatment were not done optimally, and the patient continued to receive the treatment. We were very careful about the tolerance of the treatment, but also the compliance. And right now, we continue to have a CT scan completely normal in favor of a complete response considering the targeted lesion. We did not do again a lumbar puncture because it's quite aggressive. We are waiting for the symptom, but finally, the patient is in a good way with the treatment. And so, to make a summary of the chronology of the story of this patient, we see that our surgery can be a good option for this patient. Our local treatment can be something we need to consider. In this case, probably letrozole was delivered too late in the management of the disease, and probably today this patient will receive hormonal treatment at the first time of the relapse. We see also that there is some hope for this patient when we see that the duration of the treatment, the activity of cobimetinib in this disease compared to what we see with chemotherapy is clearly in favor of this kind of treatment for our patient. And if we want to conclude about the management of this patient in the relapse setting, you have to remember that also it is a rare disease, a low incidence. We have a high prevalence because we are speaking about an indolent disease and young age. That means that we need to anticipate all the pathway, all the management of the patient at the time she will relapse, and how we can be able to organize the treatment of this patient. We consider that chemotherapy is a standard of care, but looking to the response rate we have, I can say we can do better. For sure, single-agent endocrine treatment, looking to the activity, but more importantly, the tolerability, is clearly a better option when we can. The results of the BEV is really important in this disease. I did not report the analysis of atezolizumab plus BEV in this cohort of patients, but it could be interesting to discuss. We have seen very nice results with a single-agent MEK inhibitor, and this is in favor to consider probably combination in the future. Thank you very much for your attention.
That was really great. I'm not used to having speakers finishing early, so thanks for that, first two speakers. You know, time for a couple questions from the panel, and again from the audience. We're going to have time at the end for questions. You know, Rachel, we talked about hormonal management. What do you take into consideration when you're choosing hormonal management, and which is your preferred hormonal regimen?
Yeah, that's a great question, Brian, because you know what? I don't take too much into consideration, meaning that I don't rely on ER/PR testing to make that decision. Of course, the vast majority of our patients with low-grade serous ovarian cancer will be ER positive, and then about 60 to 70% will be PR positive. But it hasn't necessarily been shown that that level of ER or PR positivity is clearly associated with response to endocrine therapy, at least with single-agent drugs like aromatase inhibitors. So like in the upfront maintenance setting, as we were discussing the use of letrozole as a maintenance therapy, I wouldn't necessarily exclude a patient from receiving letrozole based on their level of ER or PR positivity. So really, I take it into account mostly the clinical factors. So for a patient who has more aggressively behaving disease, a patient who has ascites, a patient who, is having a poor prognosis, I would generally avoid single-agent endocrine therapy and reserve it more for either the maintenance setting or patients with more indolent disease.
Great. You mentioned letrozole. Just to piggyback on that, if someone received letrozole in the maintenance setting for a year, stopped, and recurred 2 years later, would you use letrozole again, or would you cross that off of your list as options?
Yes, if they received it as maintenance and then were off treatment and later progressed, I would certainly consider using it again. Yes.
Dr. Gershenson, similar question, but for chemotherapy choice in the second line. We know it's not as active when we're thinking of hormones, but there's still some activity. What do you consider when you're choosing which chemo to use in the second line?
Yeah, so for chemotherapy considerations in the recurrent setting, that's what you're asking me. So if they're platinum sensitive, platinum resistant is not probably as applicable to low-grade serous as it is to high-grade serous, but nevertheless, if they are, quote, platinum sensitive by our usual definitions, I will use something like Doxil, carboplatin, bevacizumab, for instance. The other regimens that are available would be weekly paclitaxel, gemcitabine cisplatin every 2 weeks, or topotecan, which is not it's pretty ineffective drug as far as strictly chemotherapy.
Great. And Isabel, we talked about the benefits of bevacizumab. If you're going to give chemo in the second line, do you add bev to all of the regimens, just like we sort of do with the high-grade patients?
Depend, because in France we are using BEV in the first line, and as you know, in terms of reimbursement in Europe, we have BEV once. So now we have biosimilar available. We start to increase the number of lines of chemotherapy adding BEV. That means that I see more and more patients with BEV again after BEV. The question is also, do we see that there is a place for surgery? Because if we anticipate to move to the surgery, we did not use BEV before. It's much more complex for the surgeon. It's one of the discussions we have in the multidisciplinary tumor board. The other question I agree with David is that at the time of the management of this patient, she received carboplatin gem because of OCEAN. But there is some data, retrospective data in the literature who said that PLD is perhaps more interesting in low-grade serous than gemcitabine. So right now we are more in favor to use carboplatin, PLD, and BEV than gemcitabine. I have a question also for the team that we always discuss for hormonal treatment. We have some patients, young patients, not able to receive any surgery, so we continue to have an ovarian activity in the relapse setting. In this case, what is your best hormonal treatment when you decide to move to hormonal therapy, when you have a young patient with ovarian activity?
Oh, if they still have ovary in place, I always continue them on Lupron until time of menopause through surgery or natural menopause.
Okay.
Do you do that as well, too?
Yeah, the issue of, in general, yes, I keep them on Depolupron, but, Depolupron also is, long-term is not good in terms of bone health and other issues. So I've talked to our reproductive endocrine infertility colleagues about, do they have any thoughts about it? And the answer I got was they don't know. So I don't know. I think maybe we should be thinking about restricting that to a year or two or whatever, and then just leaving them on letrozole. But I agree, if they have an ovary, that's the main drug that suppresses ovarian function.
Yeah, and we have to go to the next talk, but I think you alluded to the fact in these patients, fertility preservation, if possible, is something that we'd like to do, because obviously the low-grade patients are younger, and if it's an option, we always talk about that, and that's where we'd have to carefully select the hormonal regimens. So, good. So at this time, I'd like to welcome our last speaker, Dr. Rachel Grisham, to present a patient case that will give you insight on incorporating best investigational strategy for the management of this disease.
Thank you, Dr. Slomovitz. All right, well, so as Dr. Gershenson and Professor Ray Coccard have just shown us, the activity of chemotherapy is certainly limited in our patients with recurrent low-grade serous ovarian cancer, with response rates generally being less than 13% in the recurrent setting. So more recently, the use of these single-agent MEK inhibitors like trametinib and binimetinib have shown more encouraging response rates of 16 to 26%, with a median PFS of 11 to 13 months. However, these do come with their own cumulative toxicities. And in the phase 3 studies of binimetinib and trametinib, more than 30% of patients eventually discontinued their treatment due to toxicity. We see that actually in Professor Ray Coccard's case that she just did with cobimetinib, that the patient was in fact responding very well, yet due to toxicity, she discontinued her medication, leading to progression. So really the question we have is, how can we improve on these response rates that we see with single-agent MEK inhibitors, while also hopefully decreasing toxicity and improving the tolerability of these medications for our patients? So a promising strategy to try to do this is using combination targeted therapy with an intermittent dosing schedule to allow for recovery phase. Avutametinib is a first-in-class oral RAF/MEK clamp that potently inhibits MEK kinase activity, while defactinib is a selective inhibitor of FAK, a signaling target that's been shown to mediate resistance to multiple anti-cancer agents. The combination of oral avutametinib with oral defactinib showed really promising results in the phase 1 FRAME study, which enrolled patients with multiple solid tumors, including low-grade serous ovarian cancer. This study actually led to US FDA breakthrough therapy designation for the combination of avutametinib and defactinib in women with recurrent low-grade serous ovarian cancer, and led to the development of the NGOT-OV60 GOG 3052 RAMP 201 study for women with recurrent low-grade serous ovarian cancer. So this study enrolled women with recurrent low-grade serous ovarian cancer who had measurable disease via RECIST. These patients need to have received at least one prior line of platinum-based therapy, but after that, they were allowed to have unlimited additional lines of therapy and could have also received a prior MEK inhibitor. The study had several phases and answered a couple really important questions. So I want to take some time looking at the schema here. We see that the initial component of the study had parts A and B, and this is the randomized portion of the study. During parts A and B, patients that were enrolled were randomized to either the combination of avutametinib and defactinib at its standard dosing, 3.2 milligrams of avutametinib twice a week, and defactinib 200 milligrams twice a day, 3 weeks on, 1 week off, or randomized to a higher dose of avutametinib, 4 milligrams twice a week, 3 weeks on, 1 week off, as a single agent. Now, based on this randomized component, which looked at the efficacy and also the overall safety profile, the combination of avutametinib and defactinib was chosen as the go-forward regimen. In Part C of the study, the expansion cohort, additional patients were accrued at the standard dosing of avutametinib and defactinib. And in Part D, the dose optimization cohort, patients received a lower dose of avutametinib in combination with defactinib. The primary endpoint of this study was objective response rate as determined by blinded independent central review. The baseline characteristics for the patients treated both in the monotherapy arm with avutometinib and the combination therapy arm were similar. Patients had a median of 3 prior lines of therapy. About half the patients had received prior bevacizumab, and about a quarter of the patients had received a prior MEK inhibitor before coming on to the study. Now here I really want to focus on 2 things. The first thing is to compare the efficacy of avutometinib as a single agent versus the combination of avutometinib with defactinib. In blue, you see the results for the patients treated with avutometinib alone at a higher dose, 4 milligrams. And in green, you see the results of those patients treated with avutometinib and defactinib at the standard dosing. As you can see in the top line there, the objective response rate for treatment with avutometinib alone was 17% versus 31% for those patients treated with the combination. And looking specifically at those patients who had a KRAS mutation, the objective response rate was 23% for those patients treated with avutometinib as a single agent versus 44% for those patients treated with who had a KRAS mutation. So based on this analysis, the decision, of course, was made to go forward with that combination dosing of avutometinib and defactinib at the standard dosing. But then I really, of course, want to highlight here these really promising response rates that we're seeing here with these patients treated with the combination. This overall response rate of 31%, and then that response rate of 44% seen for those patients with a KRAS mutation. Now, the response rate in KRAS wild-type patients was lower, 17%, but as we know, patients that are KRAS wild-type also have a poorer prognosis in general, and unfortunately generally have lower response rates to all systemic therapies in low-grade serous ovarian cancer. It's also interesting to note that in the patients treated with prior MEK inhibitor, there was still a strong response rate. The response rate was 33% for those patients that did not have a prior MEK inhibitor, but still 24% for those patients who had received a MEK inhibitor before going on study. And these responses actually occurred pretty quickly for low-grade serous ovarian cancer. The median time to response was 3.7 months. And then the really phenomenal thing here, the median duration of response, 31.1 months. So of course, it's promising for us to see a high response rate in this disease. It's something we rarely are able to achieve, and that's a big achievement. But obviously, it's much more clinically meaningful to our patients if these responses are enduring. And so if a response just lasts for 1 or 2 cycles, it doesn't have a huge impact on our patients' quality of life. But when these responses are lasting for years, for a median duration of 31.1 months, that can really affect our patients' quality of life and overall life. This waterfall plot shows the activity in those patients treated with the combination of avutometinib and defactinib at the standard dosing, and that the vast majority of patients, 82%, had a reduction in their target lesions. And just highlights again here that there were multiple responses in patients who had received prior MEK inhibitors, demarcated here by having hash marks on their bar. Now, toxicity. This is the big thing, right? Because we're talking about using a MEK-RAF clamp with a FAK inhibitor. And if we're hitting the pathway in multiple ways, are we adding extra toxicity? That's our big concern with single-agent MEK inhibitors. But with this intermittent dosing schedule of these drugs, the toxicity has actually been quite tolerable. So in the RAMP 201 study, the main reason for dose interruption or discontinuation of study drugs was elevation of blood CPK. Now, this is a common side effect across MEK inhibitors and is generally asymptomatic. Despite this, still only 10% of patients actually discontinued study drug due to toxicity. There were 4 deaths while on study, which were all attributed to disease progression and not to the study drugs. Non-laboratory toxicities most commonly included GI toxicity, like nausea or diarrhea, peripheral edema, rash, fatigue, or blurred vision. Part D of the RAMP 201 study was this dose optimization cohort that looked at a lower dose of avutometinib, 1.6 milligrams twice a week, 3 weeks on, 1 week off, in combination with defactinib. Now, based on a pre-specified analysis, it was looked at the percentage of patients who progressed within 4 months of treatment. For those patients treated in parts A, B, and C with the standard dosing, which was 12% of patients, versus the percentage of patients who progressed within 4 months of treatment in the low-dose cohort, which was 22% of patients. Based on this analysis, the low dose of avutometinib was found to be suboptimal and is not going to be pursued going forward as a starting dose for avutometinib in low-grade serous ovarian cancer. I think this is important because when we have these drugs that actually work and are actually shrinking cancer, the dose does matter. And so I think we have to be mindful of that. And when we have other options to try to mitigate toxicity, such as use of prophylactic antibiotics and prophylactic topical steroid cream to help prevent rash, or use of antiemetics to prevent nausea, I'd really suggest that we move towards those interventions first before going straight to dose reduction so that we can really get these durable benefits for our patients. So based on these promising results from the RAMP 201 study, an application has been submitted for accelerated approval for avutometinib and defactinib in patients with recurrent low-grade serous ovarian cancer who have a KRAS mutation, with a PDUFA date of June 30th of this year. So we're anxiously awaiting the results of that decision. But I would like to highlight that this is specifically for those patients that have the KRAS mutation. And that's because that's where we saw that incredibly high response rate of 44%. Now, we still need more information about these KRAS wild-type patients because we know they have a worse prognosis. And it's hard to tease out what the relative benefit is of avutometinib and defactinib when we haven't compared that to standard of care treatment for these patients. So luckily, the confirmatory randomized phase 3 study is ongoing right now. GOG 3097 NGOT OV81 RAMP 301 is the confirmatory randomized phase 3 study for women with recurrent low-grade serous ovarian cancer. This study is actively enrolling patients right now. Patients that are eligible for the study have a confirmed diagnosis of recurrent low-grade serous ovarian cancer. They've received at least one prior platinum-based therapy, but are allowed unlimited additional priors after that. They're allowed to have received a prior MEK inhibitor, they're allowed to have received prior bevacizumab. They need to have measurable disease, and you need to know before they go on to study if they have a KRAS mutation or not, because it's a stratification factor. But just to be clear, you do not need a KRAS mutation in order to go on this study. You just need to have had somatic tumor testing performed or be willing to have it performed prior to randomization. The patients are being randomized 1-to-1 to either treatment with avutometinib and defactinib at that standard dosing, or investigator's choice of therapy, which could be pegylated liposomal doxorubicin, weekly paclitaxel, letrozole, or anastrozole. Now, for those patients that are randomized to the investigator's choice, they do have the potential to cross over to the investigational arm at time of confirmed progression if they remain eligible for the study. And this crossover option, of course, is incredibly important for our patients, as we generally don't go on clinical trials hoping to get the standard of care arm. The primary endpoint of this study is progression-free survival via RECIST using blinded independent central review. So this is our last case of the morning, Doreen. So Doreen is a 42-year-old woman with recurrent low-grade serous ovarian cancer who was first diagnosed in 2020. She underwent a primary debulking and had afterwards received adjuvant IV carboplatin and paclitaxel for 6 cycles, and then she received letrozole maintenance based on that fantastic prospective study from Dr. Gershenson and his colleagues. At the time of diagnosis, she had somatic tumor testing performed, which showed a KRAS G12V mutation, no other actionable alterations. After 5 months on letrozole maintenance, she progressed and was treated second line with IV liposomal doxorubicin. After 4 cycles of that, she progressed again, was changed to IV bevacizumab with oral cyclophosphamide. Progressed again after 5 months of that, was changed to trametinib at the standard dose of 2 milligrams daily. After 2 months of trametinib, she required a dose reduction due to rash, down to 1.5 milligrams, and did respond to that with a partial response at 4 months, but ultimately progressed at 12 months. She was next treated with single-agent carboplatin for 3 cycles, but then again progressed with measurable disease. So in summary, Doreen has measurable disease with low-grade serous ovarian cancer. She's had 5 prior lines of therapy. She has a somatic KRAS mutation, and she's received a prior MEK inhibitor, trametinib. So is Doreen potentially eligible for the ongoing RAMP 301 study? Well, looking back at the schema here, we see that patients do need to have measurable disease, so she meets that criteria. She's heavily pretreated and has 5 priors, but that's okay because there's no limit on prior lines of therapy as long as you've had prior carboplatin. She's had somatic testing performed previously, and she has received a prior MEK inhibitor, but that is not an exclusion criteria because as we saw in the phase 2 RAMP 201 study, multiple patients responded to this combination of avutometinib and defactinib, even if they were treated with prior MEK inhibitors. So this patient is potentially eligible for the RAMP 301 study. Thank you.
That was great, thank you. And you know, from my perspective, it's so cool that we're talking about a potential FDA approval specifically for a drug in low-grade serous ovarian cancer. I'm sure Dr. Gershenson, that's been a career goal of yours over the last 80 years or so. Questions from the audience. It's early, but we have 15 minutes. I'm really thrilled that we have such a great full room of people, but we really need some questions. Microphones are around. Otherwise, we're going to start asking the audience questions. No, you know, Rachel, this is it's super exciting, and you know, thank you for your leadership on the trial. You mentioned the PDUFA date, which is a date that the FDA has to tell us by, is coming quickly. You know, just in a couple of months. Whenever a new drug is approved, though, there's always this time lag till it gets used. So what can you say as a key opinion leader, as a leader of the trial? You know, what are your thoughts on its implementation? What are going to be some of the delays in implementation? And how us as a group of teachers, right, we teach all of our colleagues, we're here at the Education and Learning, how can we help spread the word of this potentially, game-changing trial?
I think that is such an important point, Brian. And yes, I mean, I know we saw it with PARP inhibitors, right? Like that, how long did it take for people to start getting PARP inhibitors? And how long did it take for people to start getting HRD testing? It takes a long time because a lot of our patients are treated by medical oncologists that are treating lots of different types of cancers. And I don't know how they stay up to date on how to treat every single type of cancer. I would find that incredibly challenging. And so, you know, I think we are lucky to have very informed patients who advocate for themselves and advocate for each other. And I know a huge number of patients that take it upon themselves to really try to help inform their colleagues and try to help inform other patients to spread the word about the newest research and ongoing clinical trials in low-grade serous ovarian cancer so that they can be a true partner with their physician and make sure that they're aware of the newest data. But I think it definitely is a challenge, and you know, I think one of our goals definitely is at scientific meetings to get the word out about this potential impending approval and make sure, number one, that patients are having somatic tumor testing done, right? Because you don't know if your patient has a KRAS mutation unless you've done that testing. So really all patients with ovarian cancer should be having germline and somatic tumor testing done. So if patients with low-grade serous ovarian cancer haven't had that done yet, now would be a great time to do it because it usually takes a while to get those results. But I think it's great for us to kind of work together and keep spreading the word to inform our colleagues and our patients about these expanding options.
Yeah, no, that was so important what you said, particularly I think the biomarker testing, knowing what the profile is, the signature of these patients. Sooner than later gets us prepared. Isabel, we're doing these trials. We have a great partnership and got GOG-led trials, which is phenomenal. But we know, and we're really globally doing trials together. However, we know that drug approval is not, it's different all over. Where are you on the European side of the registration and getting this to our patients?
Yes, Brian. As you mentioned, we need at the European level to have the results of the phase 3. Okay. So that means that we will be a little bit late compared to US to have access to this combination. The good news we have, at least in France, because it's not the case in all the European countries, we have this national rare cancer network dedicated to rare gynae cancer, where in fact all the patients with a diagnostic or a probable diagnostic of rare gynae cancer should have to receive a second opinion by an expert, and the case should have to be discussed in a dedicated multidisciplinary tumor board. We have 20 centers in charge of that, and it is very easy for us because we can promote the trial.
Right.
And when the drug will be available, I hope it will be quicker for the patient to have immediately access to the drug, because the expert will immediately recommend to treat the patient with the drug.
Okay.
And this is also something that I hope we can help, because in terms of recruitment, we will be able to support as much as possible GOG for the phase 3.
Okay. That's excellent. And if I'm still waiting for some questions, so please feel free to step up to the mic or just shout them out. You know, Dr. Gershenson, you know, I think whenever we talk about FDA approvals, we change we talk about the words treating to curing. If we get with this FDA approval, do you think that we're going to be in a position now or at someday that we can actually cure patients? Or are we still going to be just pushing over, like making their disease slow, indolent course lasting longer? What are some of your thoughts on that?
Well, I would say we're already curing patients
Okay.
with frontline therapy who have not recurred. The preliminary evidence suggests that if they haven't recurred within about 6 years, they may be cured.
Okay.
We need a much longer follow-up to know that, but that is preliminary. I think once a patient recurs, that makes it very difficult, if not very rare, to actually cure those patients who develop a recurrence. But if they haven't, and the median time to developing a recurrence after initial diagnosis is about 2.5 years.
Okay.
So, but if they haven't recurred by 6 years, we're following a number of patients who are doing well after that point without recurrence, and they're still on, usually still on aromatase inhibitor therapy.
I would say that we have we always have those special cases, right? And those are the hope that we hold on to for our patients. But in this modern era with all these recent approvals, like in endometrial cancer, all these patients who previously would have progressed so quickly on all their lines of therapy, and now these enduring responses to immunotherapy, and patients with advanced disease who have these ongoing responses for years and years now who may be cured. But yes, it's going to take us a lot longer to know. I would say that I have a patient who's been on selumetinib, heavily pretreated patient, been on selumetinib now with a complete response for 16 years. She went on treatment in 2009. And so, it's hard to know if that's a cure or not, but I think that, that's a really long response. And so for some of these patients, we're just going to have to keep following and keep watching. But some of these patients can have really lasting responses that just keep going on for years and years and years, which is hopefully a cure.
I would agree. Even if somebody does recur and you don't know that they're cured, they may live for several years. Most of that time, unfortunately, they're on some type of treatment, but some of our treatments are not that toxic. So yeah, but it's hard to always know if they've recurred once, are they really cured or not? But
So hard to define, yeah.
And I know you focus on their quality of life. So not only are they living, maybe they're living with disease, but they're still having their quality, productive, doing things they want to do. Isabel?
Yes, I just want to make a comment about when we can consider that the patient is cured. Also, David mentioned that after six years, we don't see so many relapses. We have seen that in the case of my patient, she relapsed 9 years after. So we have to be careful to continue the follow-up of the patient. And more importantly, we know that surgery can bring some advantage for this patient. And if we are not able to follow, we take the risk that when the patient relapses, the surgery cannot be offered because the disease is too important. So it is something that we need to keep in mind, that surgery can be an option also for this patient. And so we need to continue to follow up for a long time.
Yeah, no, that's a great point. We didn't talk about second-line therapy, but surgery is always an option. I know there are a lot of surgical focused colleagues here. And I think there, from my perspective, it's patient selection. not only, the performance status, sites of disease, where it's located, and making sure you have the right surgical team on board. Dr. Gershenson, anything to add there from surgical management?
Yeah, well, for recurrence, yes, secondary cytoreduction, we believe has a role. And as you've, I think, alluded to, you have to be very selective, though. I think if a patient, generally, most of us think that if they have what we call carcinomatosis with small implants spread throughout the abdomen, they're not really optimal candidates for secondary cytoreduction. On the other hand, if they have one solitary mass or maybe a couple in the same area, then they are. But this is a very inexact science in selecting patients, and I'm sure it will evolve as we get more information, but that's sort of those are the criteria I think we're currently using for selecting patients for secondary cytoreduction. Because if you can't cytoreduce them to no gross residual, maybe that surgery wasn't very beneficial.
That's great. And Rachel, you did a nice job describing the ongoing trial, which I think is a great trial, the 301 trial. The three things that, for me, that really stick out is, number one, it doesn't matter the biomarker profile. It's really for all patients. We're going to be looking at the behavior in the different biomarkers, but it's allowed for all patients. The second thing is patients are allowed to get the prior trametinib. So even if it's sort of the same class mechanism of action, they're testing to see if this is still working in those patients with trametinib. And you highlighted this, and I have several patients on the trial, which is extremely important. Even if they're randomized to the control arm, when they progress, there is allowed crossover. So a lot of patients, we talk to our patients about getting the best cure or at least the best standard of care. These patients will, if they're randomized to the control arm, they still have the option of getting the standard of the experimental arm, the study drug, even after they're recurrent. With this long indolent course of the disease, it's nice. Patients are excited about that, which is a great. I think you guys did a really nice job. Congratulations on designing the trial and setting ourselves up for success in the future.
Thank you.
Since there's no other, we're going to wrap up now. So, Rachel and David and Isabel, thank you very much. Thank you for the audience. I know it's early on the last day of SGO 2025. It's been a great meeting, but we're really excited that you're here and had the opportunity to be with us this morning. A final reminder that this is an accredited program, allowing you up to 1.25 hours of CME credits in compliance with ACCME regulations. Please complete the pre- and post-test questions, as well as the post-meeting evaluation will result in distribution of your credits. Here's this. As a reminder, please use the QR code on the screen or on the paper that's at your table now to complete the pre-test survey if you've not already done so. The post-test survey and online evaluation will be emailed to all of the attendees. To claim CME credit through the GOG, you must complete the evaluation. CME certificates will be sent via email within 5 weeks. Your feedback helps the GOG evaluate the success of its programs and develop content for future events. The session will be available on demand. Please go to gog.org for more details if you wish to access and watch this program again. That's all for this morning. This concludes the symposium. Once again, the GOG Foundation would like to thank Veristem for their unrestricted educational grant and support of the symposium. Isabel, David, and Rachel, thank you very much. Travel safely home. Really a great job. And everyone, please have a great day and enjoy the rest of the meeting. Thank you.